All right, welcome to The Explainer. Today we're going to dive deep into one of the most urgent medical mysteries there is. We're solving the case of chest pain.
You've probably heard this before, right? It feels like an elephant is sitting on my chest. It's such a powerful line because you immediately know what that feels like. But when a doctor hears that, what do they do? I mean, where do you even begin with something so serious?
Well, the stakes are about as high as they get. Chest pain is a super common reason to end up in the ER. So think of this like a detective story. The very first job is to rule out the most dangerous suspects, the life-threatening stuff. You have to clear the most serious possibilities off the board before you can even think about anything else. Okay, so let's get into our investigation. In this particular mystery, every single symptom, every little detail is a clue that could crack the case wide open. The first big clue is often the type of pain. It's this thing called visceral pain. It's not sharp, not something you can poke. It's a deep, dull, squeezing kind of pressure. And here's the real kicker for investigators. It can refer, meaning it shows up in a totally different part of the body, like your jaw or your arm. That's a huge clue that the problem isn't just a muscle, but something deep inside, like the heart.
So, where does the investigation kick off? Well, it always begins with the most crucial piece of evidence there is, the patient's own story. Their testimony is what guides every single step that comes next.
The questions start coming right away. Context is everything. Were you just relaxing on the couch, or were you out mowing the lawn? That one question can completely change the direction of the entire investigation. Next up, location. Can you point to the exact spot with one finger, or is it more of a widespread feeling across your chest? See, a pain you can pinpoint often suggests something different, maybe musculoskeletal. But that vague, spread-out pressure, that points the investigation down a very different path. And then there's this. What affects the pain? Does taking a deep breath make it shoot up? Does leaning forward help ease it? Or is it just relentless, no matter what you do? These are the fine print details of the story, and they matter a lot. So all these individual questions, they're part of a system. You've got onset, location, duration, all 7 of them. This is how a clinician builds the whole narrative of what happened. It's like gathering all the witness statements before you move on to the next phase of the case.
Okay, next section. Once the story is on the record, it's time to profile the patient. You know how detectives look into a person's background? In medicine, that means assessing risk factors.
And profiling is so important because different suspects, different medical conditions, have completely different rap sheets. For a heart problem, what doctors call acute coronary syndrome, or ACS, they're looking for clues like smoking, high blood pressure, or family history. But for a blood clot in the lung, a pulmonary embolism, or PE, the profile looks totally different. Maybe a recent surgery, not being able to move around much, or a history of cancer. And the profile gets even more detailed. Other things from your past, like any recent medical procedures or even cocaine and meth use, are also critical clues. They can point the investigation in a very specific direction. Seriously, no detail is too small. All right, section 4. We have the testimony. Now it's time for the detective to examine the scene for some cold, hard evidence. In the hospital, this is the physical exam. So what are they looking for? Anything that's out of place. Are the blood pressure readings different in each arm? Is the patient sweating? Can the pain be reproduced just by pressing on the chest wall? They're listening to the heart and lungs, checking for swelling in the legs. Each one of these checks either adds evidence to a theory or helps cross one off the list. You know, sometimes the most powerful evidence isn't even spoken. When a patient instinctively clenches their fist and puts it over their chest to describe the pain, that's called Levine's sign. That one single gesture is a classic, silent clue that tells the investigator we're likely dealing with that squeezing, cardiac-type pressure. Okay, so we've got the story and the physical evidence in hand. Now the investigation moves to calculating the odds. Clinicians use specific tools to assess the risk that the main suspect, a cardiac event, is actually the culprit. One of the most common tools they use is the TIMI score. It sounds really technical, I know, but it's basically just a 7-point checklist. Its job isn't to give a final diagnosis, but to measure the level of risk and help everyone decide, okay, what do we need to do next? So let's just run through it. Each yes gets a point. Are you 65 or older? Do you have 3 or more risk factors for coronary artery disease? Do you already have a known diagnosis of it?
Have you used aspirin in the last week? Had severe angina episodes recently? And then there are a couple of technical ones based on EKG changes and cardiac markers in your blood. You just tally up the points. It's a really logical way to quantify a patient's risk.
So, for example, if a patient gets a score of 3 out of 7, that lands them in a medium risk category. What does that tell the medical team? It means this person likely needs to be admitted for more observation and testing. It's not a guess, it's a data-driven decision that guides the entire rest of the investigation.
And this brings us to the final act of our mystery. This is where we pull all the evidence together, the story, the risks, the exam, the scores, to finally reach a diagnosis and solve the case.
And this is the most important part, really. The entire process is designed to be a safety net. It's only after the most dangerous suspects, like a heart attack or a lung clot, have been thoroughly investigated and ruled out that the detective can finally turn their attention to more benign causes, like acid reflux or even just a pulled muscle. Safety first.
But the investigation is never simple, which is why a good detective always keeps an open mind. These are like little pearls of wisdom. A torn aorta can actually show up looking like a stroke. Young people can have heart attacks. And some people, especially those with diabetes or who are elderly, they might have totally atypical symptoms without that classic pain at all. Every case truly is unique.
Ultimately, chest pain is your body's version of a fire alarm. It's an urgent, non-negotiable signal that something is wrong. The methodical investigation we've just walked through shows exactly how seriously that alarm is taken. The only question left is, are you prepared to listen when it sounds?